So this is a lecture on sexually transmitted diseases or sexually transmitted infections, STDs or STIs. Hopefully this will be useful for not just OBGYN, but other rotations such as family medicine, internal medicine, pediatrics, because you'll see a lot of these in other fields. Pretty gross topic. Why do I care? In your OB patient, you want to prevent or treat these infections because they can lead to poor fetal outcomes, such as miscarriages, blindness, and you overall want happy mommy, happy baby, as well as healthy mommy, healthy baby. So, get a 2 for the price of 1 here. In your GYN patient, a lot of these diseases can lead to impaired fertility down the road, so you want to treat them before they have a chance to cause any lasting damage. And they have systemic health effects in that you'll see a lot of these diseases manifest in other ways, not just in the reproductive tract, as well as just mental health. Not only can HIV and syphilis present with neurological symptoms, but it can be uncomfortable for your patient and embarrassing for your patient, so just something to address. Overall, you want to just improve population health. In Louisiana, it's one of the worst states for HIV. It's high rates of HIV transmission, diagnosis, as well as high rates of syphilis. So you need to be aware of where you work and how to improve outcomes in those areas. So what questions do I need to be asking? In any patient, especially in OBGYN, pain. Not just, oh, does it hurt? But do you have pain during sex? Dyspareunia can be an important symptom that you don't want to miss. As well as dysuria, any pain, burning when you pee. Lower abdominal pain, pelvic pain. These things are important clues. What kind of pain is it? For dyspareunia, do you have pain on initial contact or during deep thrusting? Important things to know and document. For things such as herpes and genital warts, you can have pain just because you're irritating the skin mucosa just by your patient sitting down. So, things you need to know. Large warts around the rectum can be very painful during bowel movements, so it's embarrassing for the patient, but you need to be aware of them. Vaginal discharge is not a fun question to ask, but important. Color, consistency, thin, clear discharge isn't as concerning as a patient who says she's got thick, white, or green discharge. Those are bad signs, and you need to be prepared to investigate those. Odor is another common question that you should ask. That fishy odor can be a giveaway for you. A history of STDs. Not only do you need to know so you can get an idea of what to screen for and how to tailor your screening, but it can also prompt a good discussion of safe sex practices. And you can have your patient be aware of the outcomes of repeated infections. Partner history, I put plus minus. It may not be relevant for the patient, but it could be relevant. In that you need to know what kind of STDs their partner has, but also is their partner being treated. So let's say that you pick up gonorrhea on a patient. If she's not getting her partner treated, she's going to have a recurrence of that gonorrhea. So very important. Can also discuss things like condom use and how that's really the only way to prevent STDs. So again, important things. Embarrassing to the patient, but need to ask these questions. Physical exam. So not only do you want to just inspect the external genitalia, look for ulcers, lesions, excoriations if they've been really itchy, but you're going to do your bimanual, your pelvic exam. You may see an inflamed cervix. So two things that you need to be aware of. Chandelier sign, also known as cervical motion tenderness. So you're in there, you're doing your bimanual, and your patient is screaming in pain, she's jumping off the table, she's quote-unquote grabbing the chandelier off the ceiling because she's just jumped off the table so fast and so high because she's in so much pain. Never actually seen that, but those are some classic questions. But you can also feel pain on bimanual when you're palpating on the stomach, that lower abdominal area. So be aware. Also know that normal vaginal discharge, the pH is less than 4.5, so it's pretty acidic. You have white to clear discharge that's thin. It's not thick and mucousy, but it can be common for women to have, leukorrhea, as they call it, physiological leukorrhea during different parts of their menstrual cycle. So it's nothing for them to be super alarmed about if it's kind of described in that same fashion. On wet prep, you will see epithelial cells and lactobacilli, which are common vaginal flora. Nothing to be alarmed by. So, labs. You should do a wet prep. If you see discharge, don't be afraid to swab it, put it on a slide, and look at it under a microscope. You'll see some fun stuff sometimes. Gonorrhea and chlamydia, you can do the probe. So if you're down there doing a pelvic exam, go ahead, do a swab for the gonorrhea and chlamydia. Or if you're doing a pap smear, it's already in that test. So you don't need to go around and do another test. It's already in there. You just got to put in the orders for it. Your patient, let's say she's really in here to discuss one thing and she's not going to get a pelvic exam, so you can do a urine test because it's just as effective for screening. You also need to tell your patients that HIV and syphilis are separate blood tests. So which STDs are we going to go over? Vaginitis. You should know that candidiasis and BV are not technically STIs. They're not sexually transmitted. So if a woman thinks that it's sexually transmitted and she's really upset about it, you need to make her aware that it is not. Trichomonas, gonorrhea, chlamydia, syphilis, HIV, herpes, HPV, all pretty big players. Granuloma inguinale, chancroid, lice, and scabies. We're going to go into this, but not as in depth. So, vaginitis. Symptoms: we're inflamed, we've got an inflamed vagina, you have discharge, dyspareunia, itching, pain, pretty common complaints. So something merits further investigation. For candidiasis, a good old yeast infection, classic white, cheesy discharge. I think that description is always known as cottage cheese discharge. So I guess if you like cottage cheese, I'm sorry. Vulvar erythema is also common. You may see excoriations just because they've been itching so much. It's really uncomfortable, so another thing to be aware of. You will have a normal pH since you're not messing around with the bacterial flora down there. On microscope, on your wet prep, you will see budding yeast, hyphae. It'll look kind of like spaghetti sticks almost. 10% KOH, this will help lyse the epithelial cells, so what will be left is just the yeast and hyphae. Your treatment will be azoles, so it can be over-the-counter. Monostat works wonders. Prescription strength if you need something a little bit more powerful, so fluconazole is a good go-to. Most women can tell you if they've had one before that they'll say, this is exactly like my previous yeast infection. So you may not need to do a really heavy physical exam. You can just be like, oh, here's your prescription. BV. So what causes this? Basically, what has happened is natural bacteria flora, happy bacteria living down there, one of which the big players is lactobacillus. For some reason, and a big reason is douching, is that these lactobacilli are kind of kicked out, and so this allows anaerobic bacteria like Gardnerella to grow in its place and take over and cause a lot of symptoms. I always tell women, don't douche. There's this big myth perpetuated by TV, I'm not really sure why, that women need to be douching. That somehow inherently the vagina is a dirty place and you need to clean it with harsh chemicals. Not true. The way an attending described it to me, and I'll never forget this, is the vagina is a little bit like a self-cleaning oven. You know, let it do its thing, don't mess around with it, it will do it on its own. Back in the 50s, Lysol was advertised as a douching liquid. So I'm glad we've come a long way and that we're no longer using Lysol, but it can be common, especially among older women, that they douche. So tell them, do not douche. You're making things worse. Symptoms, fishy odor is a pretty classic description. You'll see a thin grayish discharge. The pH will be different because you have disrupted flora. And clue cells, which, as you see, are epithelial cells that have just been swarmed over by anaerobic bacteria. So, pretty classic description. So, how do we diagnose this? Well, one way to do it is to do a gram stain. You can actually look at the bacteria. But something that's a little bit easier is AMSL's diagnostic criteria. So you just need 3 out of 4 to make this diagnosis. Thin white discharge, which we've talked about, which shows that it's not an inflammatory reaction. So it's not something that is red, bleeding, or gray, white, a mucousy discharge. Clue cells, which we discussed, the pH being increased past 4.5, and the whiff test. People always describe this. I've only done it once and I didn't smell anything, and because this patient didn't have BV. But you just take the 10% KOH and you're supposed to be able to smell a strong fishy odor that supposedly smells terrible. Thankfully, I have not had to experience that smell. Treatment, good old flagyl, some metronidazole, PO 500 milligrams BID for 7 days. I usually see the PO. A lot of OBGYNs like to do the PO one, but I have seen ER physicians do the gel flagyl. It can get messy, so I think that's why OBGYNs do PO. And I found this book online. It's called Permanently Beat Bacterial Vaginosis. I really just put this picture in because the captions kind of made me giggle a little. Great to be able to live a normal life again, says Anne. Feel so fresh and clean. So it can be something funny to laugh about, but it can really affect a lot of women and affect their outlook and overall just mental status, because it can be super uncomfortable. So it can be funny, but it can also be pretty serious for these women. So another big cause of vaginitis, trichomonas. It's a protozoa, and the classic descriptions are yellow-green discharge with strawberry cervix. I don't know why food is always being used as a description with a lot of medical terms, but I guess it works. So strawberry cervix, so basically a very inflamed, angry-looking cervix. Diagnosis, you want to do a wet prep. And this can actually be really interesting. You will see these little guys moving all over the place, swimming, having the time of their life. So you want to see motility. Treatment, again, flagyl. You can do one-time dose or 7 days, but metronidazole is the way to go. Gonorrhea. It is gram-negative diplococcus. Not that interesting of a fact. But symptoms, it can be asymptomatic, especially in women. A lot of STDs can be asymptomatic in women because all the internal organs are on the or all the reproductive organs are internal. Thick discharge, dysuria, abdominal pain is very common, especially lower pelvic pain. So when one comes in with lower pelvic pain to the ER, you want to think of things like appendicitis, ectopic pregnancy, but also something as kind of on the lower end of the spectrum of severity, gonorrhea. Complications, you can have pelvic inflammatory disease, PID. It can cause just massive inflammation all over your pelvic organs, between the bladder and the uterus. Also within the fallopian tubes, you can have a large amount of scarring, and that can lead to infertility in women. So it's just something you need to know. Fitzhugh-Curtis is a pretty highly tested concept. I'm not sure why. I have seen it once, and you just have adhesions between the liver capsule and the rest of the abdomen and pelvic organs. And it's described as violin strings. So, pretty messy. In OB, you want to treat gonorrhea because you want to prevent neonatal conjunctivitis. This can lead to blindness, and this is why infants get that antibiotics in their eyes when they're first born. It can also lead to septic arthritis. In pediatrics, you'll see a large, hot, swollen joint, a septic joint, and you need to consider septic arthritis from gonorrhea. Chlamydia, it's a gram-negative bacteria. Again, not that important, or it is important, not that interesting. Symptoms, again, often asymptomatic, and you see a lot of the same symptoms as you do in gonorrhea. So kind of fuse those two together in your head, gonorrhea and chlamydia. Discharge, dyspareunia, abdominal pain, also important things. It can also lead to PID with gonorrhea. In OB, again, neonatal conjunctivitis, but also preterm birth and spontaneous abortion, so be aware of those things. A systemic manifestation is writer's arthritis. Can't see, can't pee, can't climb a tree. This is one of those causes. So again, gonorrhea and chlamydia, they usually come together. How do we test for them? The old school way, you can culture them, but now we can actually do nucleic acid amplification tests. You can do tests in the urine, so like I said, cervical samples are often the best, especially since you're already in there. You may be doing a pap smear. It's already in there, so just go ahead and get it. You can also do just a gen probe, so separately, a swab. But if they're already dressed, ready to go, and that was something you forgot to do, go ahead and get the urine test. Treatment. So why are we treating both gonorrhea and chlamydia? This is a commonly held belief that you should treat for both because often they come together. And I thought that for a very long time, like, you do ceftriaxone and azithromycin because you want to treat for gonorrhea with the ceftriaxone and the azithromycin for the chlamydia because they come together. But as one of my pediatrics attendings pointed out, we've got tests, so if one comes back positive and the other comes back negative, why are we still treating for both? The tests have really good specificity and sensitivity, so why treat for both? And it's so you can cover resistant strains of gonorrhea and chlamydia. It's common now, since gonorrhea and chlamydia have been around and we have used antibiotics like all the time now. It has led to some resistant strains. So if someone ever asks you, why are we treating for both gonorrhea and chlamydia, why am I getting all these drugs? Because they come together and you want to cover resistance. And that's another good discussion to have with your patient, is if they have repeated gonorrhea and chlamydia, to make them aware that resistant strains are out there. And it used to be that we could just give you some antibiotics and call it a day, but we need to be a little bit more judicious and practice safe sex habits. Syphilis. So syphilis is a spirochete, Treponema pallidum. It's actually really interesting. It has a very long, entwined history with mankind. I believe there's mummies with evidence of syphilis in their skulls. If you read Guns, Germs, and Steel, Diamond makes reference and talks about syphilis and how it was one of the few diseases that Native Americans were giving the Europeans versus the other way around, where the Europeans were basically decimating the Native American populations with diseases that they had brought, and so this is one of the few diseases that went the other way. And if you do a lot of reading and literature, it's really referenced quite frequently. I know Ibsen referred to syphilis in some of his works. So, interesting. If you're interested in medical anthropology, this is a pretty big topic, and syphilis and mankind have been together forever. But moving on, symptoms, primary syphilis, that's your classic painless ulcers known as chancres, and you'll usually see that in the labia or in a man around the penis. So large or small, painless ulcers. That can heal, and you can have secondary syphilis, which is characterized by a skin rash, so often on your soles and your palms of your hands, as well as lymphadenopathy and mucocutaneous lesions. So here's a picture of tertiary syphilis with the gummas, which is basically granulomatous lesion. So you can have that in all sorts of mucocutaneous sites. Luetic syphilis, which is also known as aortic syphilis, aortitis. So inflammation of basically the ascending or proximal descending aorta, and it can lead to a dissection, almost dissection-like picture. Neurosyphilis is by far the most commonly tested manifestation of tertiary syphilis. So something like TOPS dorsalis is common, degeneration of your spinal cord, or other encephalitis, other encephalopathies. In OB, you need to be aware of this because it can lead to an IUGR, or spontaneous abortions. You can also see hepatomegaly or hydrops on ultrasound of the fetus. When the baby's born, this is really not so much for OB, but for peds, you can see the Hutchinson's incisors, as well as the Saber shins. So, things to be aware of. You want to screen for this at the first OB visit, and again, in high-risk populations, 28 to 32 weeks. So, a high-risk population would be someone who has a repeated history of STDs, or someone who is in a sex trade industry. So, things to be aware of. Diagnosis can be made with actual visualization of these spirochetes with dark field microscopy, but you can only do this when you can see these spirochetes, and that's only when you have the chancres, when you can take that little sample and have bacteria in it. Otherwise, the way to go is your VDRL, which stands for Venereal Disease Research Laboratory, so it's named for where it was conceived, or your RPR test. So these are good screening agents. They're looking for antibodies. You can get false positives with something like lupus or some other diseases. It's common, so you need to, if you have a positive, you need to follow it up with a confirmatory test. So FTABS, fluorescent treponemal antibody absorption, or MHATP, microhemagglutination assay for T. pallidum. They're pretty interchangeable, as well as the VDRL, RPR. Whatever you use will be dependent on where you work, and whatever institution you're at will have their sort of preferred test. So screening, VDRL, confirmatory, FTABS, where I work. So syphilis, how do we treat this? Penicillin, penicillin, penicillin. Thank God for penicillin. 2.4 million units IM, and by IM I mean 1.2 million units injected into each butt cheek. It sucks. It is not fun, but it does the trick. And I think you use your buttocks because it's just a large, chunky area. I'm not really sure why, but that's how I've always seen it. 1.2 million in each butt cheek, I guess. You need to be aware of something called the Jarrett-Herxheimer reaction. It's basically what happens is you're giving your patient penicillin, all these bacteria are dying, like by the millions, all over the place. And so when they're dying, they're releasing exotoxin. And this is what happens when your body is reacting to the exotoxin. You get almost a SIRS-like picture. You get flushing, tachycardia, hypotension, and there's really nothing you can do about it. It's just supportive care. So give them fluids, watch them, make sure they'll get through it, and they should, as long as there's no other confounding sort of issues. So just support them through it. If you're allergic to penicillin, you can use doxy or ceftriaxone. If you're pregnant, unfortunately, you just gotta suck it up. You desensitize them, which is exactly how it sounds. You start off with a little bit and slowly work your way up to the dose using penicillin. So penicillin is the easiest way to treat it, the most reliable way to treat it, and possibly the safest way to treat it. So penicillin. Back in the day, before we knew about penicillin, the treatment for syphilis was arsenic. And while yes, it did its job and it killed the spirochetes, it also probably killed the rest of the body. So, you know, whatever floats your boat. Thank God for penicillin. Moving on to HIV. As you know, this is a retrovirus. I'm not going to go too in-depth to HIV just because it is a very broad, intense subject. If you plan on going into OBGYN, you may not be responsible directly for the management of HIV patients, but you should just know because it can change your screening guidelines for other diseases as well as your other general health measures. So anything for like for OB, ER, family medicine, these are just general things to be aware of, but usually they should be managed by an infectious disease doctor who specializes in HIV treatment. But it is interesting, you may see tons of patients with HIV. Where I live, I think I saw at least an HIV patient, at least one on every single service. So for psych, OB, surgery, all the way through, I saw HIV patients all the time. It was pretty common. But I've also met people who didn't grow up or who didn't do medical school in the South, and places out like the Northwest, HIV is pretty uncommon. And I had a resident who's not from Louisiana who told me she saw maybe 3 patients with HIV her entire med school career, versus some people like me, HIV is pretty common where I live. So just be aware of where you're practicing and kind of how HIV is being treated there. There's a lot of good social services. Social workers can be awesome for something like an HIV patient. So it can be a project for these patients, but it's important. So now that I'm off my soapbox, AIDS the definition is HIV plus a CD4 count less than 200 or an AIDS-defining illness, which we'll discuss in a little bit. You have an HIV positive patient that comes in that has been diagnosed with HIV. You need a list of their medicines, and if their doctor who's managing their HIV decides to change, you need to have them tell you, like, we're changing from this medicine to this. You also need to be aware, how compliant are they with their drug? And a good indicator of that is their CD4 count and their viral load. Undetectable viral load is a good sign. It means they're taking their meds, they're seeing their doctor, they're doing great things. You also want to discuss safe sex practices. I had a patient who, because she was HIV positive and her partner was HIV positive, they never used any sort of protective barrier form of birth control, and she thought it was okay because, hey, I've got HIV, my partner's HIV, we can't get HIV anymore, it doesn't get any worse than this. But unfortunately, they could have been passing different types of HIV, so resistant strains from one person to the other person. So if patient had, strain A, which was resistant to drugs A, B, and C, and her partner had a different strain that was resistant to drugs D and F, that would render those drugs useless for both of them. So we still need to encourage safe sex practices and overall general safe health practices. Still telling them to exercise, eat right, all that good stuff. AIDS, opportunistic infections. I'm not going to go into too much detail. It's a little bit beyond the scope of OBGYN, but you should be aware of these infections, because they can signal and kind of give you a hint as to where your patient lies in terms of their CD4 count. So it's a good chart to kind of be aware of. With CMV and toxo, these in your OB patients, these are torch infections, so you need to be aware of them and get ahead of them and treat them as soon as you see them, because they can be passed on to the baby. So just a good chart of AIDS opportunistic infections. Candidiasis, like I said, we discussed that it can be a sign of impaired immune function, so HIV, diabetes, also common. Histo, coccidio, crypto, Kaposi's. The rest I've actually never seen ever. I hear them talked about all the time, so I guess it just means that we're better at treating AIDS, so these opportunistic infections aren't coming out in full force as they were back in the 80s and 90s. So if you know your patient's CD4 count, and this is really more for the doctors managing HIV patients, you can begin prophylaxis against PCP, toxo, and MAC. So you use TMP and sulfamethoxazole and azithromycin. On OB, you have an HIV positive pregnant woman, encourage hard adherence. Tell them to still see their doctor for ID all the time. Zidovudine is a drug that is really favored for pregnant patients, and when the baby is born, they often place them on Zidovudine for 6 months to a year, just until they know for sure the baby is HIV negative. You also want to encourage as many practices to decrease mother-to-child transmission. This is why it's important to know the CD4 count and the viral load, so you can plan what kind of delivery your patient who's HIV positive needs. If they've been really good with all their meds and they're on top of it and their viral load is undetectable, you may decide to do a vaginal delivery. It is possible. However, if they have a high viral load and they're just not that compliant, a C-section may be the best way to go to decrease the exposure to the baby. No breastfeeding, because that is how HIV is transmitted, so don't tell them they can breastfeed. On GYN, this can affect your PAP guidelines. You need to test for PAP initially and within 6 months and a year, because impaired immune response can prevent them from clearing an HPV infection. And encourage other STI screening, gonorrhea, chlamydia. This can be something that a gonorrhea and chlamydia infection may not be cleared out as easily, so you may have to test for it a little bit differently or more frequently. So, things to be aware of. Diagnosis is made with an ELISA and a Western blot. These are, the ELISA is an antibody test, and that is what you screen with. A Western blot is a confirmatory test. This is really just, you want to make sure you're 100% positive, so you need to confirm with a Western blot. You can also do an RNA PCR. While the ELISA checks for antibodies, the RNA just PCR is literally looking for pieces of HIV. So this is very accurate. Now, it's not really so much relevant for OBGYN, but for pediatrics, the way you test for an HIV infection, you don't do an ELISA, because baby still has antibodies, HIV antibodies from mom floating around in its bloodstream. So an ELISA is going to come up positive even if the baby has no HIV. So an RNA PCR is the way to go for diagnosing a neonate. Treatment is really complicated, and this is best left to a doctor who is trained to do HIV treatment. But heart therapy is the standard. If you are prescribing one of these drugs, you are a terrible doctor and you're probably headed off to jail. I don't know, but you should be aware that one drug, you are doing nobody a service, and you're probably doing people a disservice, because you will cause resistant strains of HIV just because they are so good at replicating and so fast at it that they will become resistant to a single drug. So you need to get a good combination of all these drugs. A lot of people do like 2 reverse transcriptase inhibitors and 1 protease inhibitor, or I don't know, it's really up to the managing doctor. And a lot of these drugs come by already packaged together, so like Atripla, there's a giant chart of them that you don't really need to know the generic or the market names, the brand names of the combined drugs, but you should be aware of the classes. I'm not going to go into too much detail, but you should be aware that all the navirs are protease inhibitors. Raltegravir is an integrase inhibitor. But you should also know that Zidovudine, an NRTI, is used commonly for pregnant women. And efavirenz, an NNRTI, is a teratogen. So if your patient is pregnant or looking to get pregnant, you need to make that aware to their managing doctor so they know to kind of figure out a new drug for them. Put a little asterisk by tenofovir because it's not technically a nucleoside reverse transcriptase inhibitor, but a nucleotide as an NTRTI. Herpes. Pretty common. It's a vesicle, can be painful, shallow ulcer, pretty regular shaped, small. Diagnosis. So they always talk about a zinc smear, where you'll be able to see multinucleated giant cells. I have never even seen this word in the clinic setting. I don't even think you can order for one, but they love talking about it. The most common thing to do is an HSV serology test. So you can just test for antibodies. It's also common to see this ordered if you're doing an LP because you suspect encephalitis. HSV serology is ordered. But that is the lab associated with herpes. Treatment, acyclovir or famciclovir or valacyclovir, extremely common. HPV, genital warts, good old genital warts, or anogenital warts because you can see it in the rectal area. But you'll basically see papules, warts, cauliflower-like lesions. Again, I don't know why we describe things with food, but it's common. That's called a condyloma acuminata. So it's pretty giant. It literally looks like a cauliflower. Diagnosis is really just made on clinical suspicion. So your physical exam is key here. Treatment, so there's just basically 3 big categories, or 4 big categories technically, but podophyllin and trichloroacetic acid, these are topical. They kind of dissolve, help dissolve away the wart. Imiquimod is used to boost the immune system to help you get rid of that wart, help fight it off. Cryotherapy and surgery are used kind of towards the end. And cryotherapy, you are freezing the wart off. In surgery, you're basically going in and excising, and that would be something you would do for something like a condyloma. And I've actually scrubbed into condyloma removal in the anal area. It was not fun, and you have to use a special mask because you can have aerosolized HPV. So having HPV in your respiratory tract is probably not a good idea. So they actually have these filtered masks and a vacuum-like hose that just sucks in all the air around that area while it's being kind of burned off. So it's kind of a cool surgery. It's just extremely painful and unfortunate for the patient. HPV also causes cervical cancer. I'm not really going to go into too much detail in this video about it because it merits its own discussion for PAP guidelines and staging, but you should know that 16 and 18 are the ones most linked to cervical cancer. You should also know about vaccines: Gardasil, which covers 6, 11, 16, and 18, and Cervarix, which is 16 and 18. I've only seen Gardasil around, but seen Cervarix. It was apparently common in some third world nations, but Gardasil is the way to go. We start as young as 9 for girls up to age 26. It just hasn't been studied, if the effectiveness hasn't been studied beyond 26. So, again, things to be aware of. Encourage your patients to get the vaccines, whether they are boys or girls. So this could be useful for peds. When I was studying in Denmark for a short period of time, I learned that they vaccinate all the boys and girls to cover for HPV, because that whole herd mentality to cover everybody. So encourage boys and young girls to get this vaccine, because it has just done wonderful things. So the other thing to be aware of: painful versus painless lesions. This is tested. I haven't actually seen these, but a painful lesion should lead you to suspect a chancroid, which is caused by H. ducreyi, a beefy red or rolled granulation tissue. You should consider granuloma inguinale, which is caused by a bacteria in the Klebsiella family. A regular round raised lesion, that's a chancre, which is syphilis. Chancroids are irregular, deep. You have inguinal lymphadenopathy, and you treat that with azithromycin or ceftriaxone. So there's a good picture of that, of chancroids on the labia. Granuloma inguinale, you use doxy or azithromycin, and it's pretty angry looking tissue right there. In syphilis we have discussed, but here is a good picture of that lesion. It looks almost like a giant pimple, I would say. So lice, scabies, lice and scabies. Lice, tiny little buggers, and they're usually around pubic hair, at the base of the hair, clinging to the hair. Scabies, you usually see that within the folds of the skin. I have seen scabies once. I have never seen lice, actually, even as a kid. Like, no one in my class ever had lice. But you use permethrin cream for both, and ivermectin for scabies, especially on inpatient. So that is all for STDs. Hopefully that was useful. Any questions, let me know.